am so excited because I'm interviewing Dr. Stacy Smith-Foley today. She is a breast radiologist and she recently joined the Learn, Look, Locate team of incredible medical advisors to help us be empowered and educated about all things regarding our mammograms, breast ultrasound, and just, prevention from a screening perspective. So, Dr. Foley, we're going to dive deep today because as a woman who was diagnosed with stage 2B breast cancer with no family history, I want to ask you more about understanding and educating women so they know more than I did about their mammogram report. But I'd love to know a little bit more about you and why you are a part of Learn, Look, Locate.
Well, I am a dedicated breast radiologist practicing at a community-based cancer center in Little Rock, Arkansas. I have been solely practicing breast imaging since 2006. It is absolutely my passion. I am completely confident in knowing that this is what God intends for me to do with my life. And I am blessed that I get to do it every day. And in the process, I get to help women. So that is why I'm very excited to be part of Learn, Look, Locate, because this is a wonderful website bringing accurate educational information directly to patients in a friendly way, in a digestible way, in ways that, people learn in different ways. Some people learn by reading, some people learn with videos or with imagery, and you have it all. So I'm very excited to be here.
Thank you so much, Dr. Foley. I think this is an area that needs so much education and attention. And so together we have been working, just so anyone who's listening, on some questions that are so important for women to understand, because I think women need to take their mammograms more seriously. I personally had no family history of breast cancer. And from my understanding, correct me if I'm wrong, 80 to 85% of women who have no family history get diagnosed with breast cancer. Is that correct, Dr. Foley?
That is correct. It's really the minority of patients who develop breast cancer that have family history. And even the smallest percentage of breast cancers diagnosed are in those women who have a genetic predisposition. So family history is very important. If you have family history, you may need a higher level of screening or some supplemental screening, but all women need to be getting a mammogram. My little saying is that if you have breasts and you have birthdays, you're at risk. And you need to be getting your mammogram starting at age 40 if you don't have any family history. And getting your mammogram each year. No every other year, no stopping at age 75. As long as you are relatively healthy and you have at least a 5-year survival rate, there's really no age at which I would recommend that you stop having your mammogram. I have a collection of ladies in their 90s with breast cancer that are undergoing conservative treatment for their breast cancer, but all of them stopped getting their mammograms. And by the time they came in, their tumors were larger than they would have been had they been getting anal screening.
Wow. Well, I'm going to segue into dense breast because I do want to talk about that before we get into the questions. I personally was getting notes that said you have dense breasts, but I was getting normal mammograms. Yet I had a walnut-sized tumor. I was also getting 2D mammography. I think, and one of the reasons why I started Learn, Look, Locate is to break this down so that women truly understand the risk factors behind getting dense breast and how important it is to get 3D mammography and also get supplemental screening. But nobody who I know truly understands what dense breasts mean. And it's just so important that we discuss this. So can you break it down so that people understand what that means?
Absolutely. So having dense breast tissue is it's a two strikes situation. In one way, having dense tissue makes it harder for us to find breast cancer when it is present. The phrase that I like to use is, because the glandular tissue is white and breast cancer is white, it's like trying to find a snowman in a snowstorm. So there's a masking effect. The dense tissue can potentially mask or hide breast cancer. The second issue is that having dense tissue is an independent risk factor. It raises the relative risk by 4 to 6%. So it is a significant risk factor, even if you don't have any other family history. If you have dense tissue, you really need to be getting supplemental screening at minimum with ultrasound. So if you don't have any family history and you've had a risk assessment and your risk is average, it's less than 20%, and you have dense tissue, you really do need to be getting an ultrasound. Insurance coverage varies from state to state and from policy to policy, but even if you have to pay some out of your pocket, you need to be getting an ultrasound. I had my ultrasound this year and I had 16 cysts in my breast. And even looking back at my mammogram, I can maybe see 1 or 2 of the areas that are probably cysts in my left breast. I did the same thing last year and I had 16 cysts last year, but they're not all the same. They are in different locations. Some are larger, some are smaller, some have gone away, and there are new ones. So our hormones can cause cysts to form, and cysts are not harmful. They don't turn into breast cancer, but they can complicate your mammogram. So really the best practice with dense tissue is to get both a 3D mammogram and supplemental screening with ultrasound, either handheld ultrasound or automated ultrasound.
Now, do you feel that the general public knows this?
I don't. No, I don't. And, you know, the FDA, they oversee mammography facilities across the country. They are mandating a change in the letters that go out to patients that are written in language that's understandable. And so that change will not take effect until September of next year. But essentially, the words that are put into place on that letter have been chosen to try to be more understandable. So moving forward, when you get your letter in the mail, it will say that you are dense or that you are not dense.
That's it?
So, well, basically, yes. I mean, it's better than in the past where there weren't necessarily notification across the nation for dense tissue. I think it's good because it also tells those women that are not dense that they are not dense. We have a lot of ladies who come in to see us who are just certain that they have dense tissue and they don't because they feel lumps in their breasts. Just because you feel lumps in your breast does not mean that you have dense tissue. And really the only way to know whether or not you have dense tissue is with a mammogram.
Okay. So there's so much more to cover, but I want to dive into this because I know there's maybe we should segue into the category of density so people truly understand. So
there are 4 categories of density: A, B, C, and D. A is predominantly fatty replaced. My analogy for that is A is like a glass bottom boat on a glacier lake. You can see
everything.
Every pebble, right?
Right.
So B is scattered fibrolangular densities. That's between 25 and 50% glandular elements. So you can see through the tissue pretty well, but there is potential for some masking. C is heterogeneously dense, which is between 50 and 75% of the tissue is glandular. And then D is extremely dense, and that's 75% or greater percent of the tissue is glandular. So the 4 categories. Sometimes the mammogram letters will tell you which category you have, A, B, C, or D. I am a C. My density is heterogeneously dense. And so for ladies who are C and D, they would qualify for supplemental screening at minimum with ultrasound. Now, if they have family history, or if they've had a risk assessment that indicates that they're at a higher risk, really MRI is the better test. It's the test that finds the most breast cancers. So if you get your ticket punched to have an MRI, I would select that over an ultrasound.
Interesting. Okay, good to know. I still don't even know what category it was. All I know is I kept getting letters that said dense breasts, and I thought, oh, great, they're not fat. Now I learned, my friend today says, great, they're not saggy. So the misconception is so
Yes, a
horrible,
lot
and
of
that's,
misinformation
yeah,
about that.
yeah. So what we're trying to do is make sure that people, I call it, take your mammogram seriously, take a closer look, because I just saw it as a routine, check the box, and never ever thought I'd be a survivor, but here I am. So let's talk about ultrasound imaging, because when they saw something suspicious for me, right away they wanted to do breast ultrasound. And I want to share from personal experience that the minute I got the ultrasound, the woman who was doing it looked at me, and I looked at her, and she couldn't say anything, but I knew, because obviously she could see it very clearly, and she handed me a Kleenex. So
Yeah.
yeah, it was pretty powerful. Went to the dressing room, cried big time. But it's just, you're sitting here like, can you just say, and they're not allowed to say anything, but the energy around the whole experience. But really, what is ultrasound imaging of the breast? What's happening here? And why are we all not getting it? Because if it was able to be picked up like that with an ultrasound, why are we all not getting it? Is it cost? Is it money? What is it?
I think part of it is cost, also resources. Ultrasound is kind of a high utilization test. It takes the technologist a long time to perform a handheld comprehensive
Yes.
ultrasound of both breasts. For
Okay.
that reason, many centers are offering this automated whole breast ultrasound now, or ABUS.
Mhm.
And exactly your experience is what many women will experience when they have an ultrasound. Ultrasound uses sound waves to better characterize the tissue. So the technologist uses a handheld probe or a paddle with ABUS, and they apply gel or lotion on the breast for better contact and for better imaging. And then they scan, a portion of the breast or the entire breast. And when they identify something, they image it, they measure it. They may use some of the advanced tools with ultrasound, which include Doppler imaging to determine if there's any associated blood flow. At our center, we use an advanced tool called shear wave elastography. Elastography determines if a lesion is soft or stiff. Soft lesions tend to be benign, stiff lesions tend to be malignant. So that's just an additional tool that we have that helps us figure out what needs to be biopsied and what has the greatest potential of being breast cancer. Now, one of the downsides with ultrasound is that we find a lot of things with ultrasound that are not breast cancer, but that are also not clearly benign, right?
Okay. Mhm.
So that's the downside. There are some we would call those false positives. When we find something that we think needs to be biopsied, but the biopsy result ends up being benign, that's called a false positive. And ultrasound finds more false positives than the mammogram does. But ultrasound also helps us better discern what is going on. Like, I recently, just this past week, had a lady come in to see me, and her nipple was kind of drawing in, and it had been happening for a couple of months. And on the ultrasound, she had at least 7 masses that really you could not clearly see on the mammogram. All of the masses, you could tell the tissue was distorted, the nipple was retracted. You could tell on the ultrasound something was going, or on the mammogram, something was going on, but the ultrasound more clearly showed that this patient has multiple masses in more than one quadrant of the breast, and she ends up with a diagnosis of multicentric breast cancer. Ultrasound also lets us look in the areas that are difficult to visualize. So, for example, right behind the nipple, that is a very busy area on the mammogram. Yes, that's where things can potentially hide. I like to say it's kind of like a roundabout, right? there's a lot going on and you're really not sure what's going on. But the ultrasound can definitely help with that. It also helps us look under the arm, right? A lot of women will have a positive lymph node at the time that they are diagnosed. And oftentimes we're not able to include that lymph node tissue on the image. If the technologist cannot pull the abnormality in on the mammogram image, then the radiologist can't make the diagnosis on the mammogram. So this patient with the nipple drawn in, when we did the ultrasound and we looked under her arm, we saw several lymph nodes under her arm that had an abnormal appearance on the ultrasound. Wow. So really, the ways that we use ultrasound primarily, number one, we use it as our first look in young women and women who are under 30 who are coming in with a lump or a focal problem. We usually start with ultrasound if they don't have any family history. Okay. Secondly, we use it for problem solving. So we use it for women who come in who feel a lump in their breast. And, you know, we do the mammogram, we may or may not see a mass. In those women who are feeling a lump or their doctor feels a lump, I almost always take them to ultrasound, and I will do an ultrasound to kind of figure out what is it that they're feeling. Because sometimes they're just feeling normal tissue, whether it's dense glandular tissue or fatty tissue. Sometimes the lumps and bumps that we feel when we do our breast exam are just normal tissue. And then the third way that we use ultrasound is for supplemental screening for women who have dense tissue. We talked a little bit about that at the beginning. The fourth way that we use ultrasound, if we find something on ultrasound that we think is suspicious enough to warrant a biopsy, we can perform that biopsy under ultrasound guidance. It's more comfortable for the patient. We're able to pretty easily do the procedure, sometimes even on the same day. The fifth way that we can use ultrasound is in a woman that we have diagnosed with breast cancer and she's undergoing treatment, we can reassess the area. We can look again with ultrasound and make new measurements, and we can assess the response to the treatment that she is undergoing. So those are the five ways that radiologists use ultrasound in breast imaging.
Thank you for that. It's a lot, but women need to know. I mean, it's really important. I mean, one of the things that I was fascinated with too, once I started Learn, Look, Locate, was understanding all the different bi-rads scores. I mean, this is extensive, yes. Really diving deep. So, can you explain what is the radiologist looking for in an ultrasound? So, and then breaking it down into what is a bi-rad score?
Well, okay, so let's start with what is the radiologist looking at when they're getting an ultrasound, or when they're looking at the ultrasound, what are they looking for? We are looking for areas that don't look like normal tissue. Like sometimes there is a discrete mass. It is a lesion. It could be solid. It could be cystic. It could have a well-defined border or edge, or an ill-defined border or edge. We are looking at very specific features on ultrasound that help us determine what is the probability that this lesion represents breast cancer. Like that's our goal with everything that we do. Mammography, ultrasound, MRI. Our goal is to try to diagnose breast cancer, to find breast cancer when it is present. And we have lots of different ways through our bi-rads. The bi-rads is a common language. It's a construct that radiologists use to communicate their findings and their level of suspicion. And there's a huge book. It's also obviously available online that will talk about specific features and what the likelihood, if a lesion has this feature, what is the likelihood that that feature would indicate that this is a breast cancer? And you try to put all of those features together. Personally, I will make my final assessment based on the most suspicious feature. It can have benign, relatively benign features. Benign features would be that it looks cystic, that it's circumscribed, like it has a well-defined edge, right? But a suspicious feature would be that it's stiff on elastography or that it has blood flow. So a cyst that has blood flow or that's stiff, that could be a wolf in sheep's clothing. That could actually be a high-grade breast cancer that's necrotic in the center, and that's mimicking a cyst. So the bi-rads assessments go from 0 to 6. When you get your screening mammogram, typically you'll only get a bi-rads 0, 1, or 2. So a bi-rads 1 is that the exam is completely normal. We don't see anything that looks concerning. We haven't described any specific finding. bi-rads 2 is benign. What we see, we feel confident is benign. That could be a cyst or a lymph node or a mass that has been present for a long time, or even calcifications that don't have a suspicious appearance. We might describe that finding and then give a bi-rads category 2. A bi-rads category 0 on the screening mammogram is incomplete, needs additional evaluation. So that is when we identify something on the mammogram, on the screening, say we see a mass or we see calcifications or even a distorted area, and we are then recommending that the patient come back for additional imaging. Sometimes at the breast center or the radiologist, the technologist, we refer to that as a callback, because we're calling that patient back in for extra workup. So when the patient comes back in, we do our additional assessment, whether that's with additional mammogram views, ultrasound, and we will give a final assessment. So if it has all suspicious, or if it has all benign features, then that would be a bi-rads 2, like a cyst, like a simple cyst. That's a bi-rads 2. We think the risk of malignancy is 0. A bi-rads 3, probably benign, confers a less than 2% risk of malignancy. And there are very specific features that we're looking for. The bi-rads 4 is a suspicious finding, and that's where a biopsy is warranted. And we actually have subcategories for the bi-rads 4. We have 4A, B, and C. And with each one, the level of suspicion is elevated, right? A bi-rads 5 is a lesion that's highly suspicious. If we biopsy a lesion that we designated as a bi-rads 5, and the result came back that this was benign, we would immediately refer the patient to a surgeon or repeat the biopsy, because that's a mismatch. And a bi-rads category 6 is a patient who we know has cancer. We have already made that diagnosis. They may be undergoing neoadjuvant therapy, either chemotherapy or hormone therapy, and they have not yet had their definitive surgical treatment yet.
This is, so I had a scare the year after my diagnosis and had a bi-rads for lymph node, and they did a biopsy. So that's why I got even more obsessed with what I'm doing, because when I saw that, I was like, what does that mean? And some of us take this to the extreme. We're Googling, we want to know. So this is very helpful, because if we see this on our report and we don't know exactly what this scale means, it's just like walking in the dark. And so thank you for this very great explanation. So just a couple more questions, because I know you're super busy. I have here, what are some of the common uses of breast ultrasound? I think we covered that. I think the last few questions are, what is supplemental screening with ultrasound?
So that is really specifically for patients who are having a mammogram on a yearly basis, and they don't have an elevated level of risk. It can be performed handheld, where the technologist uses the same probe that we use when we're doing diagnostic ultrasound imaging, or it can be like a special machine that's just made for that, called an ABUS. So supplemental screening is meant to supplement and not to replace the mammogram. the mammogram really is still important. It helps us find things that sometimes with ultrasound, if you don't know you need to be looking for that specific thing, you might miss it.
Yeah.
Right? So it is intended to augment or to be in addition to the mammogram for use in women with dense tissue.
So in closing, Dr. Foley, what would you like to say to anyone watching this? I mean, someone who's just got the call back for an ultrasound. I remember those days so vividly. What would you like to say to just women in general regarding that part of their journey, but also just screening in general because of the earlier conversation about I believe the disconnect on understanding all about mammography and the advances, the artificial intelligence. I mean, from my mind, there's just so much. But from your perspective, you see this every day and getting a chance to really speak to, the masses, maybe whoever we're reaching all over the world. What would you like to say? Because I think your words are, so important for
Well,
this.
getting the mammogram is important. It's not something that we should put off.
Okay.
We're always trying to take care of everybody else. And I see so many patients who are a caregiver for a spouse or for a family member. And in that period of time, they stop taking care of themselves and they may miss their mammogram. The best chance for us to detect breast cancer at an earlier phase when the treatment is easier and is with the greatest potential for cure is with screening, right? So when we find a cancer on a screening study, it's more likely to be smaller and less aggressive. So the screening mammogram is the foundation. It's important. And women should be getting that every year. They should put themselves at the top of their priority list and they should schedule their next appointment on their way out to make sure that they will get their exam each year. The second thing I would like to say is that women who have dense tissue or women who have a higher risk, if the radiologist or if your doctor is telling you you need to be doing something more than the mammogram, listen to them and lean in. We're not just trying to make more business. We're trying to find more breast cancers. Okay.
What about women who have had breast cancer? And then what about women who are, flat? What do they do? So both, should.
So women who have had breast cancer are still, if they've had breast cancer and they still have breast tissue, they will typically be getting a mammogram each year. And they may even, in addition to their mammogram, need to be getting an MRI. I have diagnosed 3 women in the last few weeks with an additional cancer between 10 and 20 years after their first breast cancer. So if your body has betrayed you once, it could happen again. And in these women, these 3 women, I recommended to each of them that they should be getting an MRI because it is the best test for breast cancer detection. We didn't hit on this earlier, but for women getting screening mammograms, on average, we're going to find about 5 to 10 cancers per 1,000 women that we screen. We have to screen a lot of women to find a small number of breast cancers. When we do ultrasound, we add an additional 2 to 5 cancers. So now we're up to about typically 12 cancers per 1,000 women when we're doing the mammogram and the ultrasound together. When we add MRI, we find an additional 14 cancers per 1,000 women screened. So it really is the best test. And for those women who have family history or other risk factors, if they are recommending you need to have an MRI, then please do what they're recommending. For the women who are getting called back and they're worried, I know when you get that call back, you are immediately worried that you have breast cancer. Just know that about 10% of women get called back from their screening mammogram. More, kind of a higher percentage get called back when it's their first mammogram or their baseline.
Okay.
But if all of those women who come back, say we had 1,000 women and we called 10% back, we called 100 back, about a third of those will be able to say everything's fine. About a third of those will be able to say, we need to see you back in 6 months for a recheck. They'll end up with a bi-rads category 3.
Okay.
And then the last third will end up with a biopsy. And that's where we'll find that 5 to 7 cancers per 1,000 women. So out of that 100 women that get called back, only 5 to 7 end up with a breast cancer diagnosis.
Okay.
So I would say take a deep breath. Don't freak out.
Yeah,
Trust the process. And, don't put it off. Make that appointment, get in, get it taken care of. But don't borrow trouble either. Don't start planning your funeral until somebody tells you it's time.
Yeah, that's a good point. I mean, one thing with working with all of the medical advisors at Learn, Look, Locate, the advances being made are incredible. And it's just really amazing to learn about how even, mammography with artificial intelligence is helping detect more cancers more accurately, if I'm not mistaken, correct?
Correct,
More,
correct.
more precisely. There's just a lot of advances. So, and then the treatments, I was talking to someone today, and God forbid they get diagnosed, that the treatments are really good. And there's a lot of great care. And to your point, if we do catch it early, it does make a difference. So,
It's a huge difference.
I just
And
think
you also have to trust your intuition, right? If you have just had your mammogram and it was interpreted as normal, but something's wrong with my breast, that just, you feel something, or you had a sensation that you've never had before, or you feel like your nipple's pulling in or your skin's pulling in one area. Even if your screening mammogram was interpreted as normal last month, but now you notice something new, please go and talk to your doctor about it. They will probably recommend additional mammogram images or ultrasound. If you have a problem or symptom, you need to be seen specifically for that problem or symptom. You cannot rest on the fact that your mammogram was normal, interpreted as normal.
I wish I knew that then, I think that's the hardest part of, people who are getting the normal mammogram with dense breasts and thinking you're A-okay, because there's, it's just a lot more to this. That's why we try to unravel it every day. I really appreciate your time and your continued dedication towards really, you are at the forefront. You are the front line. You are where we can make a difference. So having you on board is just so important. So thank you so much for this incredible hour. And for anyone who's listening, I hope you find this very, very insightful. I wish I had this 6 years ago, So thank you, Dr. Foley.
Well, thank you for creating this resource for women like you who are going through this difficult time.
So, Dr. Foley, when I got my breast biopsy, this was just so overwhelming. And as I shared with you, I knew that I had breast cancer because I asked, being the pushy soul that I am, I wanted to see the screen before the biopsy, and I could see the cancer actually goes on when someone gets a breast biopsy, because I was out of it, so scared. Can you explain what they do with this and how it's done? So confusing.
Sure. I mean, it's something that I do every week, multiple times a week. So when a woman needs a biopsy, the first thing we have to do is determine what type of biopsy she needs. And typically whether we say she needs to have a biopsy using the mammogram guidance, that's a stereotactic biopsy, or ultrasound guidance, or even MRI, that is based on how we best can see the lesion. Now, there are findings on the mammogram, like areas of architectural distortion, that may not demonstrate a mass on the ultrasound. And so for those patients, it's in their best interest for us to perform the biopsy under the mammogram guidance or a stereotactic biopsy. But when we're in ultrasound, the process that we use at our center, the patient will come in, will sign the consent form. The risks for a needle biopsy are mild. They include bleeding and infection. And if we didn't think it was a safe procedure to perform, we wouldn't offer that. It's completely safe. It doesn't spread the tumor cells. So after our patients have signed the consent form, the technologist will scan, rescan the area, redocument the lesion, take more measurements, and then we clean the skin off with a cleansing solution. We use something called HibaCleanse. Other places might use different solutions. It's considered a clean procedure, not necessarily a sterile procedure. Like when you have surgery in the operating room, that's a sterile environment. But what we do is a clean technique. So we cleanse the skin off, and we may, we actually put drapes, those blue towels like you might see in our operating room. We use that when we perform our ultrasound guided biopsies.
Okay.
But other places will use like a paper drape.
Okay.
And then we put a covering over the ultrasound transducer to keep it clean, to keep everything clean. And then we even use gel that's sterile, that's in its own little freshly sealed packet that we use just for you, just for that particular procedure. So when I come into the room, I typically have on a gown, I put on sterile gloves, I also will wear a shield for my protection and for yours actually. And the first thing I do is I take the probe and I find the lesion again to kind of figure out what angle I'm going to take. And then I start by numbing the skin. I inject a small amount of numbing medication into the skin. I try to do this as mildly as I can, right? We buffer the numbing agent. We use lidocaine. I also use the tiniest needle. I use a 30 gauge needle like you would use if you were having a TB skin test. And I just put a very small amount of the numbing agent into the skin and just right under the skin. And then I use 2 different syringes that have 2 different types of numbing medication. I use lidocaine with epinephrine, which constricts the blood vessels. And then I use a long-acting injectable numbing medication. And I inject the numbing medication all around the lesion, on top of it, to the side of it, underneath it, because I really want to numb the entire area. I want the field to be numb. I make a tiny little puncture with a scalpel so I can get the probe into the breast. And when I'm doing an ultrasound biopsy, I'm holding the probe with one hand, and I'm seeing exactly where I'm going to put my needle and take my samples in real time, right? Depending on the lesion and the characteristics of the lesion, the size, I have a couple different types of probes that I use. One is spring-loaded, and it makes a loud click sound when I take a sample. And so with that spring-loaded device, I will take a sample, take the probe out, put the sample into the cup. I will have to come in and out of the breast with each sample that I take. I have another device that has a vacuum section attached to it. And for that one, I go into the breast one time, and I typically will place the probe right underneath the lesion. And I will take samples. Sometimes if it's a small lesion and I think it's going to be benign, I might try to take the whole lesion out. But if I think it's probably breast cancer, I'm not going to try to take the whole lesion out. And I take an adequate number of samples. For both of those, I will then place a clip, a little metallic marker to mark the location where we perform the biopsy. And when we're finished, we hold pressure for 5 to 10 minutes. We either close that little puncture with dermal glue, like Dermabond, or with steri strips, which are essentially fabric reinforced tape strips. And after we have held pressure and we've closed the skin, we will do a 2-view gentle mammogram image just to document the location of the clip. That helps us make sure that, say this is something we saw in the screening mammogram, we brought the patient back, we did extra images, it persisted, and when we took the patient to ultrasound and we found something that we thought matched, when we do that, we place that clip and we do that mammogram, we're making sure that it's in the spot that we thought it should be. Sometimes they don't match up, what we saw in ultrasound is not the finding that we saw on the mammogram. And in those cases, we might turn around and then do a mammogram guided biopsy, sometimes even the same day. Because there's always a system of checks and balances. We're always making sure that things make sense, that they match up by the size, of the location, the depth, the shape, all of those things. And for my patients, it usually takes about 2 business days for the biopsy results to come back. And I personally call my patients.
The last question I have is the clip, because I do learn a lot about wireless biopsies, or do you walk out with the wire, like, can you talk
You're
about that?
talking about wireless localization for surgery, which is
Okay.
completely different than the clip. Okay.
Okay.
The clip is necessary. And sometimes there's some pushback from patients who don't want to have the clip. And I will say to those patients that, you've come to me for my medical advice because something is wrong. And my advice is that we need to place this clip so that we can make sure everything matches up.
Okay.
If it's breast cancer and they are a candidate to undergo chemotherapy first, or even hormone therapy first, sometimes patients respond beautifully to those therapies and their lesions just melt away. And if we don't have the clip, we don't know where it was.
Okay.
So oftentimes when they're coming in, they think, I'm going to have a mastectomy. No matter what happens, I'm going to have a mastectomy. But if they respond really well, we can de-escalate and we can transform a patient that a mastectomy was her only option down to a lumpectomy would be a good choice for her. And without that clip, we're not able to help the surgeon make sure that that tissue is removed.
Now, there is a question that floats around often. When you get a biopsy, people think, and I probably have thought this as well, that when you're pulling out, are you spreading cancer cells?
No, and I said that at the very beginning, right? If we thought there was the potential for that, we would never perform biopsies with the needle.
Yes,
we wouldn't. And there are some, there are some organ systems where it's ill-advised to do a needle biopsy, but it's perfectly safe in the breast. And the bottom line is tumor cells cannot grow without a blood supply. So we do not believe, and there's no data to support that we are seeding the tract by performing these needle biopsies. If the data supported that, the technology, it wouldn't be the standard of care. Patients would go to surgery. Now, back in the day, patients went straight from mammogram and ultrasound to surgery, but the vast majority of those women didn't have breast cancer, and they would go to surgery and be told, when you wake up, you may not have your breast. That was horrible.
Yeah.
That was just awful. So as far as we know, we're not spreading tumor cells. We're not causing cancer to spread by performing a biopsy. We're just, and we're trying, in my clinic, I try to do it in the least invasive way possible. I try to take as few samples as I need to make an accurate diagnosis. I'm very mindful about that.
Yeah. Yeah, it was quite painful for me. I just need to share that personally, so it doesn't sound like mine was done in such tender, loving care the way you would have done it.
Well, but I'll be honest with you, Cynthia, sometimes when the lesion is malignant, when it is breast cancer, sometimes the numbing medication does not affect it very well. I don't know. It's just been my experience. Sometimes even when I do all of my technique and, use unicorn tear mist to help the patient have a positive experience, it's still painful when it's breast cancer. And sometimes the technologist and I will be making eye contact going, oh, that hurt. I bet this one's going to come back positive for breast cancer.
Wow.
Now, with the needle biopsy, we can't take away all the sensations. The goal with injecting the numbing medication is to take away the sharp sensations. So you're going to still experience pressure. We can't take the pressure sensation away. And for some patients who have very dense tissue and a very hard lesion, that sensation of pressure is very awkward and very, very uncomfortable, and no amount of numbing medication can take that away. So there is that little caveat. Or, maybe they didn't give the numbing medication enough time to take effect before they started taking their samples. There are a lot of different things.
Could be, yeah.
But I will tell you, most of the patients that I biopsy will say that it was not a horrible experience or that it wasn't terribly painful. Many of them, we get finished and they say, "That's it? You're finished? That's all there is to it?"
No, not for me.
It's because we build it up in our mind that it's going to be terrible, and the mind is a powerful thing.
Yeah, it is. I mean, I'm 5 years out and I look back and say, and people ask me how do you do this all day long, and not move on. I'm like, how do you not? Because if we don't get this information out there, in my opinion, it's so valuable, it's so needed, it's so important. Because what's fortunate for the Learn, Look, Locate world is that we have doctors that believe that this information needs to get out there. All of you have the same vision that I do, and that's wonderful because I don't know where I went with this, but this is just so much, even for someone who's facing a biopsy, to hear your comforting words. I so badly wanted conversations with the medical community. It's just not enough an hour to sit with the breast surgeon and say you're getting a mastectomy, or an hour to sit with the, you don't even get an hour. You get the call back to get the ultrasound, and then you sit with the emotions until you get the chance to really hear that you have breast cancer, if you're one of those to hear that. So the big
and
thing,
in a lot of breast centers, they don't get to talk. I've just learned this recently, that at a lot of breast centers, the patients don't really get to speak to the radiologist.
oh, never.
Whether things are okay, or they need to come back in 6 months, or they need a biopsy. And I talk to almost every diagnostic patient that comes to see me. Now, I don't have time to see all of the screening patients, but I do talk to almost every single diagnostic patient that comes to see me will have a face-to-face conversation with me before she leaves. Beautiful. Even if it's a brief conversation,
That's really nice. I think the human touch is what's really lacking, because the fear and the anxiety, and that is the void that I'm trying to fill here. Please help us feel safe and taken care of, even outside of the hospital, so that we can feel empowered with knowledge that will calm us down. Because even after my diagnosis, I was determined to track down my radiologist. I did not talk to her, and they gave her my message. And I only got to text her. She never called me. It was a little bit of a boundary thing. And I made sure she knew how appreciative I was that she found this. She found my tumor. I mean, why wasn't it found the year before, right? So I wanted to give gratitude. And I believe that we breast cancer patients should be applauding all of you as well. I mean, and speaking to you to say thank you for what you do. And for doing.
I will tell you, I am so touched anytime a patient sends me a note or calls to, say thank you, or drop something by the clinic. Somebody made some of those. One of my patients made some of that Chex Mix with the peanut butter and the coconut butter. And she made it's really sweet, but she made me like a little tiny container of it for Christmas and just left it at my desk. And I had a lot of exams to read in December, and I that was my fuel to get through the work that I needed to get done. Yeah. And it was just so sweet that she made it herself, and she brought it. And I actually keep every single letter or card or note that a patient has written to me. I have a little pink box that has a pink grosgrain ribbon, and they are all tucked away in there. So if I'm ever having a rough day and I need to, remind myself that I am making a difference, I pull out a couple of those notes and read them.
Awesome. And you're human too. We need to know behind the screens. There's all these compassionate human beings. I mean, the pathologist, Dr. Gilmore, who I interviewed, she's on the website. She says, not many people know us, but I'm the one behind the scenes reading the report, and we care deeply, and you might never meet us, but we're the ones who are determining whether or not it's cancer or not. And I think we as survivors need to remember all the dedication and hard work from those of you
It's a
that,
whole team, right?
yes,
There's a whole team of doctors that
yes,
take care of a patient who's diagnosed with breast cancer. And we have a multidisciplinary tumor board that we typically have every other Wednesday morning, and we actually do ours virtually. So we do
yes,
it via Zoom.
that's
And the pathologists, they're able to share their screen and show the slides. I kind of run the thing. I share my screen and I show the images from the mammogram, the ultrasound, the MRI, and then everybody is on, the surgeons, the medical oncologists, the radiation oncologists.
amazing.
And as a team, we talk about what is the best course of treatment, course of action for this
Mhm.
particular patient with her specific, his or her
Right.
specific circumstances, right?
The
And
mock is
so
over to
I don't think most patients know that there are these multidisciplinary tumor boards where there are all of these people in the background that are supporting the patient's care, the genetic counselors, the therapists like James Saviors, who does the lymphedema
Mhm.
treatment, they are participating in the tumor board as well.
That's incredible. More awareness of that too. Oh, don't get me
Yeah.
started. I mean, but I am so grateful to get these biopsy questions because I think it's, again, a big part of the journey. So thank you so
It
much.
is. Hopefully we'll make it a little less scary. I mean, we do try to do a lot of little creature comfort things. We have some aromatherapy tabs that come in different options. Like we have a citrus scent or a lavender scent,
It helps.
and it really does help.
Yeah,
Like,
I'm a
and
big
we
fan of
we do
that.
like a little breathing instruction, kind of telling patients how to breathe during their biopsy to help calm their nervous system down. And then we're really good at what I like to call oral anesthesia, which is just talking,
Yeah.
right?
Yeah, they
Coming
torture
up
me
with something we have in common or something that's engaging
to
to
keep them
that
talking.
patient to help get their mind off of exactly what's happening so they
Oh,
can get.
yeah. Mind is a million places when this is all going on for sure.
Yeah.
So thank you so much.